Okay, in this video we will be discussing about gout. What is gout? First of all, definition. It is hyperuricemic metabolic condition. Remember, metabolic condition, which is typically manifested by episodic inflammatory arthritis. It is an episodic. There are flares of arthritis in this condition, and there is disabling pain associated with gout. The patient is not able to walk. Patient presents to you with swollen and tender joints. So, what is pathogenesis? How it develops? See, uric acid is a product of purine metabolism, and there are many conditions in which there is hyperuricemia, means there is chronic elevation in the levels of uric acid in the blood, which cause supersaturation of blood, leading to crystallization, and the crystals are deposited in the form of monosodium urate in the joints, right? There they will cause ultimately they will cause inflammasome pathway activation. See, inflammasome pathway is involved in innate immune system. So the end product of this pathway is interleukin 1 beta. Interleukin 1 beta will recruit innate immune system cells, inflammatory cells, that is neutrophils and macrophages. Right, innate immune system is involved. So there will be no plasma cell involved. There will be no antibody formation. So there is no specific antibody that can be tested for gout. So basically, it is inflammation which is mediated by neutrophils and macrophages. Right. In the form of a flowchart, we can discuss it. We can understand it like that. There is monosodium urate crystal deposition in the joints, which will cause inflammasomal activation, which will cause release of interleukin 1 beta from the local inflammatory cells, and they will further recruit neutrophils. See, neutrophils are very important. They need to be remembered because we have a drug colchicine which inhibits the recruitment of neutrophils. So neutrophil is basically a target of colchicine, right? So uh, neutrophils and macrophages, they are involved. Mainly neutrophils need to be remembered, more important. Causes of hyperuricemia. See, hyperuricemia has many causes. For the sake of easy understanding, we can understand it like that. There are some conditions in which there is increased production. We know that PRPP synthetase and HGPAtase, these two enzymes are involved in purine metabolism. And if we study purine metabolism, its pathway in total, you will understand that if PRPP synthetase activity increases or HGPAtase activity decreases, it will cause hyperuricemia. Uh, Important here is HGPAtase activity decreased. It is basically seen in It is basically seen in various genetic conditions like Lesch-Nyhan syndrome, in which there is complete inactivity of this enzyme. Lesch-Nyhan syndrome is basically a syndrome of uh, self-mutilation along with neurological abnormalities, and there will be hyperuricemia also in this condition. So Lesch-Nyhan syndrome is frequently asked in multiple choice questions, and you can remember it for that purpose. Third condition which needs to be remembered is increased cell turnover. It is very obvious. It just needs to be remembered. Conditions like tumor lysis syndrome, they can cause increased cell turnover, increased, metabolism of adenine and guanine, purines, increased formation of uric acid will be there. Now, second mechanism by which hyperuricemia can occur is decreased elimination. It can be idiopathic. Most of the times it is idiopathic. We have no reason why it occurs. It is idiopathic many of the times. Second condition is CKD. Of course, kidney is involved in excretion of uric acid. In case of CKD, kidney failure, there will be decreased elimination. Third is a few drugs. There is a long list of drugs there, but there are a few drugs which needs to be remembered as far as decreased elimination is concerned, right? So now let us discuss ki how will the patients of gout present to you. See, presentation of gout can be asymptomatic, means there is increased level of uric acid, but the patient is asymptomatic. Usually, gout is a chronic condition, and there are flare-ups in between, right? And the time period in between two flare-ups is usually asymptomatic. So this is that presentation we are talking about, asymptomatic presentation. Second, the patient when presents to you is mainly because of acute gouty arthritis. It is usually a flare of chronic underlying gout. There is deposition of monosodium urate crystals. They keep on accumulating, 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 and finally inflammation sets in, which will cause most of the times, most commonly, it will cause monoarthritis. Which joints? First metatarsophalangeal. It is the most common joint involved. First metatarsophalangeal joint. And after that, ankle joint is involved, and after that, midfoot joint is involved. But most common is first metatarsophalangeal joint. It is usually monoarthritis. Only one joint is involved. If you will see, the joint will be very tender. The patient will not allow you to touch the joint. It is swollen, obviously, and it is erythematous. It is warm at the place where there is inflammation. And the patient will have severe disabling pain. He will say that this is the worst pain of my life. I cannot even walk. So, very painful condition, acute gouty arthritis. Now, third is the chronic tophaceous gout. Suppose gout, runs for a very long period of time, for years long. So there will be recurrent gout flares, and the patient is not taking treatment properly. So recurrent gout flares will cause, deformation of the joints, deposition of crystals, which will lead to formation of nodules. So it is kind of chronic deforming condition in untreated patients. So it will be seen as ongoing synovitis will be there. Subcutaneous tophi you can feel. There will be deformity of the joints. There will be bone destruction, and there will be renal insufficiency also, which is termed as urate nephropathy because of deposition of sodium urate crystals in the tubules, and they will cause renal insufficiency and CKD over time, right? So that is how it will present: asymptomatic acute gouty arthritis or chronic tophaceous gout. How can you diagnose a patient of gout? See, diagnosis is mostly clinical. I mean, suspicion is clinical. After that, we will go on to do some lab investigations, and you will find certain lab parameters suggestive of gout. After that, we can do imaging. Imaging will show certain signs. Let us see. First of all, you will see a middle-aged to elderly man and a post-menopausal woman. Right? It is a disease of elderly. It is a disease of after 40 to 50 years of age individuals. So age will be 40 to 60 years. Most of the patients present in this age group, and males are more commonly involved. Although the ratio is not very high, but males are more commonly involved than females. Then we will do serum uric acid. The normal level of serum uric acid is 4 to 6 milligram per deciliter. Though it is different for males and female, it is 6 milligrams for it is 5 milligrams for females. It is 6 milligrams, 6.8 milligrams for males to be precise. If it is more than 7 milligrams per deciliter, it is suggestive of gout, if obviously along with the symptoms and signs, right? But in case of acute gouty arthritis, the uric acid levels may be normal. Why? Because inflammation has already set in. Uric acid levels were elevated, right? The uric acid deposited in the joints, the levels fell down, and the inflammation set in. The patient presents to you, you do the serum uric acid levels, they come out to be normal. So it is like it can be normal. Uric acid levels can be normal in case of acute presentation, though it can be abnormal also, but many of the times they can be normal also. Then we can do synovial fluid analysis, which will give us the evidence of inflammatory arthritis. What are the evidences of inflammatory arthritis? First is there will be WBC count of more than 2000 per microliter. It can go as high as 20,000 cells per microliter. Right, this is the amount of inflammation going on in the joints. Second is there will be needle-shaped monosodium urate crystals, which when seen under the polarized light, they will show negative birefringence. Negative birefringence is, the crystals will appear yellow in color if there is negative birefringence. There are a few crystal arthropathies in which there is positive birefringent crystal deposition. Positive crystals will be seen as they are seen as blue, but the negative birefringence is seen as yellow. It is basically how the light passes through the crystals. Negative and positive birefringence is based on that. And remember, we use polarized light for this purpose. Then we do imaging. See, we have two modalities of, or three or four modalities of imaging. One is X-ray, second is USG. We can do CT or MRI also, but most of the cases in Indian settings they are not, done. They are not required, right? Because of the availability and stuff like that. So first of all, we do X-ray to begin with. X-ray, it is widely available, easy to interpret. Patient, when presents to you with acute gouty arthritis, we will do the X-ray of that particular joint. For example, first metatarsophalangeal joint. What we will see that the metatarsal bone, the first metatarsal bone will be, there will be resorption of the bone, and there will be translucency around the bone and the joint. There will be translucency of the joint. This is all inflammation going on. This is edema and you know the soft tissue markings, right? And uh, this is the resorption of the joint which has taken place. Let us zoom it. This is the resorption of joint. So resorption occurs in such a way that it gives appearance of G. It is also known as G sign. It is also known as rat bite sign, right? There are two more names given which needs to be remembered. One is the Myrtle sign. Myrtle sign. Second is the rat bite and G sign that we have already discussed. What will be seen when we do USG? We will do double contour sign. Why will we see double contour sign? Because of deposition of monosodium urate crystals. Suppose this is the joint. This is the cartilage, right? There will be deposition of, there will be deposition of monosodium urate crystals at this point. Let us mark it red. There will be deposition of monosodium at this edge of cartilage, and there will be subperiosteal, or you can say subchondral, just below the cartilage, deposition of monosodium urate crystals, right? So this deposition will give us a double contour sign on USG. On US, right? So this needs to be remembered. It is a very important sign. Okay, so that was all about diagnosis. Now, how will you treat the patient of gout? Treatment. Say, in case of acute gouty arthritis, there is basically flare of inflammation. Here, the main problem is inflammation. So we have to give anti-inflammatory drugs. First of all, we give NSAIDs. Which NSAIDs? Highly active NSAIDs like ibuprofen, like naproxen. Remember, we cannot give aspirin because it is uh, it causes hyperuricemia. We cannot give PCM because it is not anti-inflammatory; it is antipyretic. So we cannot give these two drugs, nor neither aspirin nor PCM. If NSAIDs fail, then we give colchicine. Remember in the first slide we discussed about the colchicine? Colchicine, it inhibits neutrophil recruitment, right? If colchicine fails to respond, then we give interleukin-1 inhibitor, canakinumab. It is a very, important drug. In case of failure of therapy, first two therapies, we give canakinumab. Now, as far as chronic tophaceous gout is concerned, here the main problem is hyperuricemia. Here we have to decrease hyperuricemia by whatever means we have. We can decrease hyperuricemia by two methods. First is we use drugs which increase uric acid elimination. First of them is probenecid. We remember from second year of pharmacology of second year, uh, probenecid is used. Second is lesinurad. Third, losartan. Losartan is we know that it is an ACE inhibitor. It is not a drug specifically, known for gout, but it has a side effect of hyperuricemia, and it can be useful in patients with gout. So losartan is one drug which can be remembered, and there are questions that are asked multiple times on losartan. Decreased production. There are drugs which can decrease the production. First of all, to begin with, we have allopurinol. It is the drug of choice, the famous xanthine oxidase inhibitor, allopurinol. We can also use febuxostat. Why? Febuxostat is very useful in renal insufficiency. We cannot give allopurinol in kidney disease, but we can give febuxostat in kidney disease. There are a few other drugs which are, reserved for some special circumstances like tumor lysis syndrome and other increased cell turnover situations. First is the resvuricase and second is the pegloticase. These are uricase analogs. What does this what do this uricase do? Uricase, it converts uric acid into allantoin. Allantoin is even less toxic than uric acid. So, uh, to convert uric acid, because uric acid is kind of toxic to joints, it is kind of inflammatory. So, we convert uric acid to allantoin with the help of uricase analogs, right? Usually, uricase enzyme is present in birds, it is not present in humans. So, we have uricase analogs which can convert uric acid into Uh, let me write it down. Uric acid into allantoin. Uricase enzyme. So uricase enzyme we have analogs, resvuricase and pegloticase. Now, problem with resvuricase is that it is short lasting. It is very effective in tumor lysis syndrome, no problem with that. But it is short lasting. It is IV given. It can be orally given, but usually it is used IV because we have to give repeat dose of resvuricase for its first onset of action. So compliance is very less and it is very difficult to administer. So we have an analog that is long acting, that is pegloticase, right? It has better compliance. So this can be used. So this is all about the treatment of gout. Uh, Let us uh, revise it once. What is gout? hyperuricemic metabolic condition, inflammatory arthritis, disabling pain, right? What is the pathogenesis? Uric acid is a product of urine metabolism, deposition of monosodium urate crystals. Chronic hyperuricemia does this, right? Inflammasome is activated, neutrophils and macrophages are recruited. They will cause inflammation. Interleukin 1 beta is mainly involved in this, right? Causes, there can be increased production, there can be decreased elimination. Increased production, two enzymes. PRPP synthetase activity will increase or HGPRTase activity will decrease. Complete inactivity of HGPRTase will cause Lesch-Nyhan syndrome, which is characterized by hyperuricemia, CNS abnormalities, behavioral abnormalities, self-mutilation. If there is partial inactivity, there will be Lesch-Nyhan-like syndrome, but there will be no CNS abnormality. There will be only hyperuricemia, right? Third condition is increased cell turnover, like tumor lysis syndrome. Decreased elimination is seen in idiopathic, which is very important because most of the patients will present to us, they will be idiopathic. CKD and drugs can also cause hyperuricemia. Presentation can be asymptomatic, can be acute gouty arthritis, can be chronic tophaceous gout, which is basically a deforming condition. Diagnosis. Age group it will be 40 to 60 years. Remember, it is a disease of elderly. Males are more commonly involved than females. Serum uric acid normal levels are 4 to 6 milligram per deciliter, but usually in gout, the levels are more than 7 milligram per deciliter. Synovial fluid analysis, there will be evidence of inflammatory arthritis. WBC count will be more than 2000, may reach up to more than even 20,000 cells per microliter. Needle-shaped monosodium urate crystals, which are negatively birefringent, they will be seen as yellow under polarized light. Imaging, two signs, two modalities. We have to remember. X-ray, we will see Martel sign, we will see G sign, we will see red white sign. USG, we will see double contour sign. I have already explained why you will see these two signs. Right. Treatment. Acute gout, there is inflammation. We have to give NSAIDs. If they fail, we have to give colchicine. If it fails, we have to give canakinumab. Chronic tophaceous gout, we have to decrease uricemia. Right. How will you decrease uricemia? Either increase its elimination or decrease its production. How to eliminate? Probin acid, lesinurad, and losartan, which is an ACE inhibitor. Losartan needs to be remembered multiple times. Questions have been asked on this drug. Decreased uric acid production, xanthine oxidase inhibitors are mostly used. The famous one you know is the allopurinol, most commonly used drug. Right, most commonly used drug in daily patients. Febuxostat is also useful, but it is useful in renal insufficiency. Uricase analogs, respiricase and pegloticase. Respiricase short lasting, used in tumor lysis syndrome. Pegloticase long acting, better compliance. Right. So that is all about gout. Thank you so much for your patient listening.